Yeah. Yeah. No, so you touched upon all the psychological component. At the end of the day, you're a dermatologist, you got to look, and you're not a psychiatrist. And how do you do your exam? How do you make sure that you can detect skin cancer really early, melanoma really early? And what are some of the tools that you're using?
Yeah, that's a great question. So there's, the proof is in the pudding. After we address the sort of the emotional element, the space in the room, we still have to be good at what we do. And predominantly we use our eyes, right? Because our job ideally is to be able to help patients prevent skin cancers in the first place. But really our job is in what we call secondary prevention, which is to diagnose it early, be able to catch these things when they're in the stage of being recognizable, being more treatable in the early stages. Um, and I love this part because we think of the examination, the act of being examined, as a passive part on the passive exercise on the part of the patient, and an active, exercise on the art of the part of the doctor. And what I like to do is I like to try to make this a very interactive
Yeah,
experience.
me too.
And so that makes it more fun for me, right? More engaging for me. But also, I feel like, right, the more our patients know, the more empowered they are, the better they are, the better we can be together. It's not about how good your doctor is, it's about how good you are together as a doctor and patient team. And so I'll always just, there's stuff going through my mind, and I'll talk through it. I'll say, hey, the first thing that I'm doing when I'm taking a look at you, I'm not even starting to go in and take a look at spots. I'm taking a look at you, trying to get a sense of your overall, sun exposure history. Do you have fair skin? Do you have light eyes? Are you actually a redhead? Um, and so that's starting to give clues. And so even from far away, walking in the room, the examination has begun. And then in the conversation, learning more about our patients and where they grew up, what they do, what they like to do. There's also information and clinical information being transferred that way. And so just talking through as we're starting to engage in that sort of exercise is good. These are the reasons why I'm looking the way I am, and asking them what I am. What I really like to do is then let's just say I oftentimes will start with the arm, because it's something that a patient and we can look at together. And I'll say, hey, we're going to look together. And I sometimes get quizzical looks. What do you mean we're going to look together? You're the doctor, you look, right? I'll say, no, actually, I'd love for you to hear a little bit about how I approach this, because you as the patient have full unfettered access to your skin. I can only see it when you're sitting here in front of me in the clinic room, right? But when you're at home, when you're on the beach, when you're, in on vacation, somewhere, you can see your skin after your shower. And so what I talk about, and as we look at your skin together, maybe that'll help you both be empowered in terms of how you look at your skin, but maybe help you spot something that you might otherwise not have noticed. Let's look at your skin. The first thing that I'm doing is not going into any individual spot, but really looking at the overall picture, right? Let's get a sense of the pattern. And depending on the patient, sometimes you can get a sense, if they're interested in art, we can use an art analogy, right? So we talk about a painting and what's in the foreground, what's in the background. The things in the background start to melt into the background, and the things that come forward are the things in the foreground, or other sort of examples, depending on what might resonate with a patient. And so really the idea is, trying to get across the sense of pattern recognition, that we're looking for things that are unlike the others, this
Yeah, I call
idea.
that ugly ducklings.
And so I think that's probably one of the most important points they get across is, the skin is full of patterns, and the patterns probably reflect some internal combination of genetics. They interplay with the environment. And so we'll get these patterns. And when we see moles that are parts of patterns or parts of families, we feel more comfortable with them because there's some rhyme or reason behind them. But when we start to see things that are just by themselves, they're kind of a black sheep of the family, sometimes we'll say, right? They're an interloper in a gathering or a picnic. These are ones that we're saying, hey, there's no rhyme or reason for why you exist. What family are you a part of? And if they don't have a family, or if they're acting in an unusual way, they're growing, changing faster, they're doing things like itching all the time, causing pain or bleeding, then we really have to wonder what is happening with that. Why is it standing out? And those are the things that we need to be aware of. I do it in a slightly more sophisticated way as a clinician, because I have some tools besides my eyes that I can use, almost like a light microscope, to look at very specific features. But that's the pattern, is what what is different from the rest, right? So the big picture is what's different from the rest. And if we can get our patients to help sort of look for that in the way that they can, then we're really somewhere, right? It's then not feeling like they're overwhelmed by the hundreds of spots on their body. Hey, these spots all belong. They're part of a puzzle. They're part of a family. What are the ones that don't belong? That becomes a doable exercise. So that's kind of the approach, and I really like making that interactive. And I say, hey, when I'm looking at this, you know, tell me what stands out to you. Ah, yeah, that was also one that stood out to me, and I'll tell you, yeah, I wasn't worried about that one because takes longer, but I think it's well worth the investment because it really does create that exercise of passive active to, hey, we're both in it together. It's a partnership.
Yeah, not to mention you take this opportunity to educate patient, right? And I mean, I think a lot of times that one of the things that patient complain the most is when we tell them to do monthly self-exam for those high-risk patients, they will sort of just give up. They'd be like, oh, I don't know what to look for, right? And it's so interesting that I recently have this new handheld camera devices that's with the tethered into this like a really large, like I think 30-inch screen.
Mm.
And when I do my exam, I basically put that device on and you can see the dermoscopic images of the lesion, but you can beam it instantaneously onto the screen.
Ah.
So now, exactly, I'm doing the same thing, right? So I'm basically taking this device, capturing every single lesion as it move along, and
Hmm.
the patient can see it in front of them and what I'm looking at, right? And I'm taking the time to say, look, this is totally benign because XYZ. This is like not even a mole, this is a lesion that we need to take off because. So, I think those interactions is really valuable to me. Yeah.
I like that. I like what you're almost, you're teaching in front of a class of one there, Steve. So it's
Yeah, I mean, I think
multitasking,
the
right?
best thing. I mean, we're gonna talk a little bit about your interest in population-based approach, right? I mean, I think what we should do is we teach our residents, we teach our medical students and other fellow colleagues, and we should figure out a way to teach the general public, right?
Yeah.
This is just about pattern recognition in a sense.
Mhm.